Chairman, professors present, colleagues, students. I'll be talking about cancer screening guidelines, barriers, and solutions. I have a pictorial view of cancers affecting different parts of the body. And the message here is that cancer can affect anybody and everybody. So cancer, as we know, is a deadly disease. Its incidence is increasing globally. We are recording newer cases, and we also have cancer-related deaths. For the year 2030, what is projected for year 2030 is that we're going to have 23.6 million new cancer cases, and approximately 16 million of this will be found in Africa. And of course, when we talk about Africa, we're talking about Nigeria basically. Again, approximately 4 in 10 cancer cases occur in countries of low to medium human development index. In Nigeria, the overall incident rates of cancers are largely unknown, though several studies have documented the frequency rates of specific cancers. In Zaria, a hospital-based analysis of cancer trend over a 5-year period documented the prevalent cancers from the Zaria Cancer Registry, which is domiciled in departments of pathology. However, we also have other documentation of cancer incidents in Nigeria. These are some of the literatures, if you want to go through them, to be able to get the current trend in cancer in Nigeria. Why do we have to have cancer screening? Some cancers are preventable by modification of the known risk and or predisposing factors, while a few are curable. Again, 26% of low to mid-income countries lack pathology services in the public sector, meaning therefore that you cannot actually be diagnosing cancer cases, you would rather want to screen. For policymakers, again, to provide intervention strategies, there must be adequate information on the cancer type, the frequency of occurrence, the age groups so affected, as well as the sex distribution. There's a lack of comprehensive data on cancer incidence statistics, which prevents proper evaluation as to knowing the extent of the health challenge, as well as provision of necessary health indices and preventive mechanisms to combat cancer. What essentially is cancer screening? The only goal for cancer screening is early detection. We want to be able to detect cancers early to enable early treatment as well as possible cure. Screening tests are not diagnostic. They do not diagnose cancer. You still have to do mandatory diagnostic tests to be able to confirm that a cancer is there. Now, there's still a lot of lingering controversies surrounding a lot of screening tests, and not all the tests that are available are beneficial. Is there an ideal screening test in the society now? Some tests manage to reach an ideal situation. But what are the criteria, the characterization you want to have with an ideal test? That ideal screening test should find cancer before symptoms will appear. It should lead to curative or treatment options. It should have few minimal false negative and false positivity. What we are bothered about is false positivity, because once that screening test says that there's cancer, then you are going to have to start a lot of invasive procedures that are not beneficial to anybody. We also want that ideal screening test to be able to decrease cancer death for which it is being screened for, and to be able to determine whether death from cancer decreased when people are screened for such cancer. 3 parameters are very important in the ideal test: increase in the number of early detection, decrease in the number of late presentation, and a decrease in the number of cancer-related deaths. Of course, this ideal screening test is also impacted on by increased survival time, which is influenced by the lead time bias as well as overdiagnosis of cancer cases. When we talk about overdiagnosis, we are saying that when your screening test is able to detect cancer that is innocuous, that has no bearing on the patient's life, by the time you diagnose that cancer, the patient now focuses on something that is meaningless. Standardization of screening tests, again, so many trials are carried out, so many studies, researches are carried out for a cancer screening test to become standardized. And those tests now undergo clinical trials to determine their accuracy, their safety, and usefulness. Who should be screened for cancer? For you to want to screen anybody, you have to define a population. What is the population at risk of a given cancer? You don't want to pick say, synovial sarcoma and you want to screen the general population. What is the incidence of synovial sarcoma in the general population? So you want to define a given cancer, you want to define the population, the age, the sex, family history, genetic mutation, as well as determine the cancer risk factors. There are 3 types of cancer risk factors when we talk about absolute, relative, and odd ratios. I'm not taking time to go into the details of all of these things because some people are familiar with this. Perhaps during the question and answer time, I'll be able to go into the details of that so that I do not exhaust my 10 minutes. Now, there are so many screening guidelines that have been developed globally. Many societies have developed screening guidelines. And as it is now, cancer is the new cash cow. Before, it used to be HIV. Now, everybody is moving into cancer because they think that they can benefit something from it. So there are so many guidelines, but I want to focus on the American Cancer Society guideline for 2017 because it's so in-depth and it's all-encompassing. And it's going to give us a guide as to how we should screen in our own environment. Now, for breast, they have highlighted mammography, self-examination, genetic screening, ultrasound, and MRI, as well as the age. I get very upset when 20-year-old females walk into the Department of Pathology with mammograms that we should interpret they have, even when there is no presence of any lump anywhere, but they have a mammogram. And then they want us to interpret that because somebody has told them that they have cancer. Now mammography test says that you shouldn't even screen anybody less than 40 years. So why are we having 20-year-olds presenting in our department? When the surgeons are exhausted in the clinic, they send patients to us repeatedly for FNAB. FNAC is not a screening tool. Even when we have done it, they will send the patient back again because there are too many patients in the clinic. Please stop sending them to pathology. Thank you. What about the cervix? There are also highlighted recommendations for cervix. Now, the new thing that we're all talking about is HPV vaccination. Even if that woman, that female, has been... Even if... Okay, all right. So, even if the female has already been vaccinated with HPV, the recommendation is that you still have to go through the highlighted yearly, 3-yearly, 5-yearly, depending on the age of that individual for screening. And the ideal test in our environment, of course, is PAP. When you do PAP alone is acceptable, but we recommend co-testing when you are between the age of 30 to 65. I'm sure that Professor Guntaya will highlight that more in detail for us. Now, we get a lot of females that come to O&G departments for infertility, pap smear. Fibroid, pap smear. And they tell us that it is opportunistic screening. What about colorectal? Colorectal, the ideal test, of course, is a fecal local blood test and visual examination. In spite of all the highlighted tests that are put there, I believe that colonoscopy is still supreme, and that if the recommendation is that if you're going to do any of these tests without colonoscopy, then it's not exactly valid. You still have to go back to colonoscopy, and if it's the only test you are doing, it is acceptable. There's a newer test that is out there now, the M2PK test, which detects bleeding and non-bleeding polyps and cancers. I'm sure we are not there yet. We are still at the level of stool blood, occult blood. What about prostate? Organized screening for prostate is not ideal. The recommendation is that we should have an informed decision. Individualized treatments for prostate cancers. You don't group men together, say once you are 40 years and above, come for PSA screening. Because the interpretation is individualized and the interpretation is based on the current events that is occurring in that man. Now, there are other cancers that, screening for them is not cost effective, especially if they are not problems in your own particular environment. What are the limitations of screening? What are the barriers to screening? Screening is not useful in all cancers, especially if they are rare cancers. Screening again should focus on major treatable cancers that are found in a particular population. And the recommendation for that screening depends on the individual risk, available treatments, early detection. Some tests work in a particular population and they don't work in another population for various reasons. And what is the positive predictive value of that test? When we say positive predictive value, what is the likelihood of a test representing cancer in a given individual when it is tested on that particular individual? What is the specificity and sensitivity? There are some tests that can pick, say you want to test for alpha-fetoprotein, but it's not specific to a particular tumor. So what value is it when you do it? And is it specific enough? So what you want to look for is a specific cancer screening test. What about exposure to ionizing radiation? This is supposed to be one of those barriers, especially as it pertains to mammography, which is harmful to men and young women. And of course, when you have too much or too high number of false positivity, it encourages unnecessary invasive procedures. Now, the way forward, of course, is we're in the era of personalized medicine, which is molecular pathology. And molecular pathology deals mainly with morphological and molecular interrogation of clinical samples with technological analysis to better understand disease evolution. Meaning, therefore, that once you integrate genomics, digital imaging, and bioinformatics with modern pathology, you get the sample, subject it to molecular analysis, as well as some genomics, and then you have a clinical pathological correlation and give us results. I'm almost done. Okay, all right. So instead of screening for everything, the way forward will be probably to look at gene testing, especially with the breast cancer gene. There is also the mutation of the breast cancer gene is associated with quite a number of cancers. Now, is there any screening policy in ABUTH area? No. Which cancers should be screened for and who funds the screening? I think this should be the focus of this lecture. About 4 weeks ago, somebody called me from the US and was asking me, is there any screening center in Nigeria for cancer of the cervix? I didn't respond for 2 weeks. because there was no response. That I do not know of any center in the whole country that is screening anybody for anything. Then she called again, she said, okay, do you have any screening thing in Zaria? Of course, I'm still here to respond. So, but in Cameroon and Ghana, they're screening for all of these things. And this is a prototype of what they have there. So the practical approach to screening for cancer, focusing on ABUTH now, is that we want to prioritize common cancers in Zaria. And already the book I talked about before that we documented the cancers that we have in Zaria, we have highlighted that we have breast, cervical cancer, colorectal, liver, and prostate. So that should be our focus. We want to identify the population at risk. How do we do that? By creating awareness programs, radio talks, sensitization of the general public, as well as provision of screening test kits, and training people, personnel that will talk to individuals that come for these screenings. We want advisors, genetic counseling units, as well as evaluation of the screening test and sorting pool. After screening, are there available confirmatory or diagnostic testing? We want this also to be provided in ABUTH, as well as standardization of treatment protocol. Thereafter, you have made a diagnosis of breast. Is Professor Yusufu's treatment protocol different from Dr. Abel's treatment protocol? We need a standardization of our treatments. Data acquisition too will also help us, especially if you are registering all cancers in Zaria. That will also give us an idea of which cancers are getting higher in number of presentation or which ones are reducing in frequency of presentation. So who funds these things? Foundations, NHIS, NGOs, out of pocket. I think we should also discourage people. I see many people going out for missionary journeys that they want to go and screen the population. What they are doing is that they are putting women in lithotomy position and taking pap smear without explaining to them the consequence of the pap smear that they are taking. Because you just take a pap smear, no history, no clinical details, no age many times, and then we look at it. When there's a pathology, who takes over? How do we explain to the patient? And I think by the time we develop a screening protocol in ABUTH area, we'll have a way forward. Thank you for listening.